Okay, so I'm going to try and provide a general introduction to this topic of evidence-based medicine, and I'm going to try and do that briefly in the 20 minutes that we've got, leaving time for some questions at the end. So the title of my talk today is Scientifically Proven to Reduce Tinnitus, and I chose that as a rather provocative title because if we look on the internet, we'll find many different kinds of treatments that have claims to reduce tinnitus or cure tinnitus, and which ones can we believe to be true, and which ones are false claims. It's a bit of a minefield. So at the end of my presentation, I hope that you will be able to maybe appreciate what makes a good clinical trial design, the methodology to test the efficacy of different interventions. I'm going to talk to you about the evidence pyramid, so hopefully you would be able to explain that to others. I'm going to explain the steps in a systematic review. I hope from the end of my talk you'd be able to understand that and interpret a forest plot, which is one of the outputs from the systematic review process. And also just to know where to go to find the latest reliable scientific evidence for treatment efficacy. So if you're a clinician and a patient asks you a question, if you don't know the answer, then hopefully you from the end of my talk would know where you might go to look as a first sort of point of contact. So that's a brief summary of what I'm going to try and cover in the next 15-20 minutes. Now, as I explained at the start, we've all seen lots and lots of different kinds of tinnitus treatments. When I was preparing for today's talk, I just put tinnitus treatment into Google, and these were some of the interventions that popped up on the first page. We've got devices, we've got pills, and we've got sort of dietary supplements. We've got kind of patches and all kinds of different things. Now, I've chosen these three as examples because if you look on those websites from the manufacturers, then the quotes are actual quotes made by the manufacturers about how these three different interventions will help people with tinnitus. So one's making claims about the latest research findings showing efficacy. One's claiming that tinnitus will be significantly reduced or even eliminated. And the lipoflavonoids is claiming to be the most effective over-the-counter solution as claimed by ENTs. So, quite bold claims. But are they substantiated? Well, we don't know. How do we find that out? Those are some sort of alternative treatments. We also have more contemporary sort of standard treatments for tinnitus offered by hearing specialists, ENT and audiology, and also psychology. So the more traditional sort of treatments for tinnitus are hearing aids and talking therapies. And one might assume that because these are ubiquitous in all countries and they're kind of the acknowledged or accepted treatment routes for tinnitus, that these would have a good evidence base and there would be strong research findings in favour of the efficacy for these interventions. But again, we might be curious and ask, what is the level of evidence for hearing aids and psychological therapies for tinnitus. So it's evidence-based medicine is something that can be asked not just about those sort of off-the-shelf treatments that you can buy off the internet, but also the more standard therapies that you might receive if you go to clinic or go to a hospital. Now, in my talk, I'm going to focus on some of these more standard treatments. And I've got a little quiz because I'm interested in your thoughts on levels of evidence. And so if you've got your mobile phone, you can scan the QR code, or if you've got a computer, you can just type in the short Mentimeter link. And the quiz question is, thinking about these 4 interventions, could you rank them for the level of clinical evidence? What's the level of clinical evidence that you believe there is for these 4 interventions? And just rank them in terms of the intervention with the highest level of evidence first, and then going down. So we've got 2 forms of cognitive behavior therapy, either delivered by a hearing specialist or delivered by a psychologist. We've got hearing aids and we've got sound generators. So just invite you to have a go at answering that. You can see the live results down at the bottom. I'm not sure that I can switch to Mentimeter while I'm in this presentation. So while the next speaker is talking, I'll have a look at the results and we can talk about that in the Q&A. But hopefully, as my presentation evolves, I will kind of talk to you about these 4 and provide the answer. So typically, when we are trying to evaluate evidence, we're talking about looking at research studies that have tested those different interventions of interest. And there are 2 common forms of clinical trial design. And I just want to kind of share those with you now. They follow a standard format. So you can see that in this slide, we recruit patients with tinnitus. We give them our intervention of interest, whatever that is, and typically we do some measures of tinnitus before the intervention, that's what we call baseline, and some post-intervention measures of tinnitus, the same measures, so we repeat them before and after, and we're looking for a change, hopefully a reduction in tinnitus score, in tinnitus loudness, or distress, or in whatever your measure of interest is. So that's a common sort of clinical trial design. Here's another variant of that. You can see it's very similar, but with one difference in that there are 2 groups in the clinical trial design, our tinnitus intervention and a comparator. Now, this is an improved design compared to the first one that we looked at, because in the first design, we don't know whether improvement is specifically due to the intervention itself, or whether it's just that because the patient was seeing a specialist or because they were part of a clinical trial, it helped them or made their tinnitus better. We often get big placebo effects. And the first trial design wouldn't be able to tease apart what is placebo from what is tinnitus specific to the intervention. Whereas the design on the right-hand side would allow you to tease those 2 things apart. The comparator, you might expect to have no effect on the tinnitus or a lesser effect on the tinnitus. And so this is what we often call a controlled design, where we have our intervention of interest and a comparison intervention. So the following bullet points just summarize some of the points that I've mentioned. So we've talked about placebo effect. We also get natural history of tinnitus. It's not always consistent. And so the left-hand design doesn't tease apart those things. Although the group allocation on the right is better, there are some caveats to that, one of which is belief in equipoise. And what I mean by that is that both the patient and the clinician must kind of share a belief that both the tinnitus-specific intervention and the comparator might be equally effective. Because if they're not, then that can sort of bias the placebo effect to one intervention or another. And if you want to have some further discussion about that, we can pick that up in the Q&A. So you might have seen this sort of evidence pyramid before. It helps us understand what high-level evidence looks like. So at the bottom of the pyramid is the lowest level evidence, and at the top of the pyramid is the best level evidence. And I've just sort of popped those two trial designs alongside the sort of stratum of the pyramid that corresponds to which level. So as you see, the control design is somewhere up at the top. It's the sort of best sort of single trial design, particularly if those patients with tinnitus are randomized to one group or another, rather than being able to choose which group they fall into. The best level evidence is what we call a systematic review. And I'm going to just talk about that briefly now. So a systematic review identifies all of the relevant published studies on a particular question of interest. And it selects those with the most appropriate methodology, often those controlled studies, often those randomized allocations. What we do is then, once we've gathered the evidence, we critically appraise that evidence, and we combine the results of those different studies to create a single estimate of whether that intervention is effective or not. We also do a little bit of quality assessment. So we look at the individual studies that have been reported, and we look for evidence of bias. And there's a sort of checklist of different kind of biases that you can look for. So I've mentioned one, which is allocation bias. Can the participants choose the interventions? Are the investigators blinded? Do they know which groups received which intervention when they're analysing the data? These are all things that can introduce bias. On the right-hand side, I've just put a little diagram of the different steps that you can see, but hopefully you get the idea that a systematic review is very systematic, and it follows a number of steps that focus on critically appraising the evidence, not just simply gathering it and collating it together. So let's have a look at some of the highest level evidence for the 4 different interventions that I've talked about. So let's talk briefly about CBT, cognitive behavior therapy, delivered by a hearing specialist. So hopefully in some of the previous sessions, if you've joined, you've heard about CBT. I'm not going to discuss the intervention per se, because today's focus is on evidence-based medicine. So there's only one randomized controlled trial that I've been able to find looking at evaluating this kind of intervention. So we can't, on the basis of one study, pool data across different studies. Here's a short summary of the trial design. So you see that it's a controlled trial design. We've got guided internet-delivered CBT using audiological support, and the comparator is a monitored waiting list. And we've got a range of different tinnitus measures, the main measure of benefit being the tinnitus functional index. Moving on to the second intervention, this is Cognitive behavior therapy again, but delivered by a psychologist. So what's the level of evidence for this? Well, there are actually quite a lot of individual studies of CBT. And again, on the right-hand side, you can see a summary of what those trial designs typically look like. So there are a range of different comparison conditions, but all compared with CBT. And again, there are a number of different kinds of measures of tinnitus improvement. We've got some kind of impact on tinnitus, quality of life, adverse effects. Those are the ones that are typically measured. Now, there's a systematic review looking at the overall efficacy of psychologist-delivered CBT, and this was published a couple of years ago by our colleagues in Europe. They've found 28 randomized control trials. So that means that they could do meta-analysis. They could try and pool the data from the different studies together to create a single estimate of how effective this kind of treatment is. They looked at a meta-analysis for each of those different kinds of comparators against CBT, and their conclusion was that on the basis of that pooled evidence, CBT probably reduces the negative impact of tinnitus on quality of life, but there wasn't enough evidence about impact on tinnitus specifically. And in terms of study bias, when we looked at the biases of those 20 RCTs, it was moderate to high. So let's just have a look at one of those findings from the systematic review. And this is a forest plot. I mentioned it in the introduction.